Good morning, everybody. My name is Ollya Fromal. I'm one of the senior residents, and I have the pleasure of sharing 3 exciting cases with you this morning. So the first case is of a 39-year-old male who presented with distorted vision in the left eye for 1.5 years. Dr. Sivalingam, can you describe this photograph to us, please?
Yep, so we have a wide field color fundus photo of the right eye. Vision is 20/20, media looks clear, disc margin is nice and sharp, cup to disc about a 0.15, 0.2. Vessels look normal in their course and caliber. Looking at the macula, we have a nice healthy nerve fiber layer sheen. Good foveal reflex. We do see this kind of focal area, hard to tell if that's artifact or some type of hyperpigmented scar. And then the visualized periphery looks relatively normal.
Great. And then we have a photograph of the left eye, the eye of interest.
Yeah, so here we're looking at the left eye. Vision is slightly decreased at 20/30. Media looks clear. Disc margin looks sharp. Cup to disc about a 0.15. Vessels look overall pretty normal in their course and caliber. And then looking at the macula.
And I have a closer view here.
Yeah, so we do see this kind of well-circumscribed area in the inferior macula, possibly suggesting either intraretinal or more likely subretinal fluid, possibly kind of an irregular and blunted foveal reflex here. And then similar to the right eye, we do see this kind of focal hyperpigmented lesion parafoveally.
Great. All right, and we have 2 photographs of fundus autofluorescence.
Yeah, so here I have a fundus autofluorescence image of the right eye, focused on the posterior pole. Overall looks relatively normal.
Okay.
Yeah, I guess yeah, that is an area, focal area of hypo autofluorescence. I don't think that correlated. We did see a lesion on the color, but I think that was more over here. So this didn't actually light up on the color, but that doesn't look like artifact. That looks real. Yeah. Possibly a scar. And then here we have the left eye. So we have this kind of well-circumscribed round area of hyper autofluorescence centered on the macula. And then kind of more inferiorly, kind of this patchy, granular, multifocal area of hyper autofluorescence, suggesting maybe some type of guttering inferiorly. And it even actually extends past the arcades.
Excellent. And then we have a few OCT images.
Yeah, so here we have a horizontal OCT cut through the right eye. Infrared image looks relatively normal. And then looking at the B scan itself, vitreous looks clear, hyaloid appears to be attached, normal inner and outer retinal laminations. So overall normal. Choroid looks normal in thickness.
Great. And then we have a few images of the left eye.
Mm-hmm. Yep, so here we have a horizontal cut through the left eye. And then looking at the infrared image, we see this redemonstration of this kind of well-circumscribed area extending into the inferior macula. And then looking at the B scan itself, vitreous looks clear. Hyaloid, again, is still attached. We have a nice, healthy nerve fiber layer here. Inner retinal laminations, fairly well preserved. And then attention is drawn to this well-circumscribed pocket of subretinal fluid. We do see this kind of shaggy photoreceptor appearance here, and then similar kind of shagginess to the RPE layer. And then looking at the choroid, it looks, I mean, it's a little bit hard to say if it's possibly thick. We don't really see the posterior aspect. Over here, it looks relatively normal in thickness. but hard to say for sure if there's a thickened choroid underlying.
I think the other thing that's important too is that the outer segments have all been kind of shredded up.
Yeah.
So that tells you it's been there for quite a while.
Thank you.
Yeah, and then a vertical cut, kind of confirming what we were suspecting this was here, kind of this guttering of subretinal fluid extending into the inferior macula. Similar appearance, again, like Dr. Polito said, this kind of shaggy appearance of subretinal fluid.
Great.
There's less shagginess, if you go back one, there's less shagginess inferiorly than centrally.
Yeah.
Maybe suggesting that the inferior changes are more recent.
Yeah.
On the other hand, you would have thought that he'd be more symptomatic if the central changes. He would have been symptomatic sooner if the central area is where it started.
Do you have any EDI OCT?
We do not, unfortunately.
And the question is that a PED that we saw that irregularity to the RPE? Is that a PED or not?
Like an old collapsed PED.
Yeah. Because if it is, then it kind of pushes you thinking one direction versus another direction.
Here we have a IVFA image of the right eye at 2 minutes. Full AV phase. Looks normal. I don't see any focal areas of hyperfluorescence. Macula looks normal, and periphery looks normal. So I would say overall normal IVFA of the right eye.
Great.
And then here we have an early frame at 25 seconds of the left eye. Looks like we're in the arterial phase, maybe some, hard to say for sure, maybe some very early venous laminar phase. But overall looks normal. And then here we are at 47 seconds. Looks like we're in the AV phase. And then we do see this focal, round, well-circumscribed area of hyperfluorescence in the parafoveal area in the macula. Interested to see how that behaves in future frames. And then the visualized periphery looks normal. Disc looks normal. And then here we are at 1 minute and 47 seconds. This focal area of hyperfluorescence looks like it's getting more intense in its signal. And then I don't see any other focal areas here, kind of more window defect, possibly correlating to some pigmentary changes in the periphery. And then we can, so nice. Now we always have a later frame at 3 minutes and 37 seconds. We do see kind of slightly expanding area around this area of hyperfluorescence.
And the last one.
Yeah, and again, a little bit more leakage here compared to the earlier frames.
Great. Thank you, Dr. Sullivan. So what kind of things are you thinking about seeing this 39-year-old with symptoms for the last year and a half, unilateral male?
Yeah. So given his age and his gender, the first thing that comes to my mind is central serous. It would go along with the chronicity of his symptoms, what we saw on the OCT, given the shagginess of the photoreceptors. Other things that can cause similar patterns, myopic CNV, although we didn't really see anything correlating to a net on the OCT. Sometimes a OCTA could be helpful. It'd be unusual. We didn't see any drusen, but AMD can cause things like this. He's too young, so that doesn't really quite fit. Other things that can cause kind of that focal area of subretinal fluid, you can think of inflammatory conditions like a posterior scleritis. The time course doesn't really fit. I mean, he's been symptomatic for a year and a half. He's not having any pain. He's not having any redness, so unlikely. Other things like uveal effusion syndrome, I'd be interested to know what his axial length is and his refraction. And then less likely kind of infiltrative or malignant processes. But central serous would be highest on my differential for him.
Okay, very good. And so you are correct, the differential for serious retinal detachment is quite broad. And given his chronicity and lack of other inflammatory signs and symptoms, inflammatory conditions as VKH, posterior scleritis are less likely. He doesn't report any history of trauma or intraocular surgery, and his anterior examination is completely within normal limits. Vascular, he doesn't have, he's a male, he doesn't have history of hypertension, and we didn't see any signs of congenital lesions on his fundus photo. All right. Is there specific questions you would like to ask him during his history?
Yeah, so getting a good history is really important. Asking about any medications, specifically steroids. Also
And
asking
Viagra.
about social history.
You got to ask about Viagra too.
Yeah, that's a good point. And then asking if he's been under an increasing amount of stress. Recent hospitalizations, other new medications is important.
Great. So he had history of cholecystectomy. He does report ocular history of stress-induced CSR in 2013 that was treated with thermal yellow laser elsewhere. And he then, as far as his medication, he denies any type of medication use, oral, nasal, topical. He is an everyday smoker, and he reports losing his family suddenly in 2019 when he correlates that with onset of his symptoms, and he says his symptom persisted since then.
Now,
anyone-
wait a second. He's 39 years old, you said? And he's had a cholecystectomy already? Is he obese?
He is on a heavier side.
All right, because besides the medications that were discussed, sleep apnea is strongly associated with central serous. And that's why I was concerned about the cholecystectomy, because that usually occurs in more obese persons. So it's something you really need to talk to the patient about.
Would you refer a patient if he denies any use of steroids and it is physically could be a suspect?
I would first ask him if other family members have heard him snoring.
And the other thing is, this has been going on for over a year, couple years. You know, when do you draw a cortisol level? I'm asking Retina. If it's, you know, if this seems to be fairly chronic, although it's not that bad, it's not seen in the other eye, and there's only one focal leak.
Yeah.
So maybe that's overdoing it, but
Yeah, I think that, again, if he has other signs, hypertension, significant obesity, multiple lesions, I get ICGs on these patients as well. If he has those things, then my thoughts about getting cortisol levels are higher. But far more common is sleep, problems with sleep, and I think that's very important in obese patients.
Is there any correlation between tobacco use that you know, Dr. Polito?
All right. So he was diagnosed with central serous chorioretinopathy. Usually occurs typically in 20 to 50-year-old males with acute or subacute central vision loss. It can occur in females, but usually in those cases it presents later in life. Other common presenting features include micropsia, refractive shift. He's actually ametropic in his fellow eye, reduced contact sensitivity and calosaturation. So there is a debate as to pathophysiology, but is thought to be associated with hyperpermeability of choroidal capillaries, and that coupled with RPE dysfunction leads to serous retinal detachment. Recurrence rate varies, can be reported up to 50% of cases. And some of the risk factors we already touched based on that is type A personality, obstructive sleep apnea, Viagra, newer cancer drugs like MEK and ERK inhibitors, pregnancy, and then some reports of H. pylori as well. So Faced with this patient, and this is to retina attendings, who has been symptomatic, who has documented history of CSR elsewhere, and has been already symptomatic for a year and a half, would you jump to treatment? Would you monitor? Is there a medical therapist that you would offer him?
I think the big question here in terms of symptomatic nature is whether this is waxing and waning. And so even if they've been symptomatic for a while, if they're going through periods where it's improving, and I would observe some more to see if it's continuing to improve. If it seems like it's been a prolonged period of time, we can certainly think about doing anticorticosteroid therapy. However, the data for that is mixed. If it's been persistent for such a long time, I do think about PDT for these cases as well.
So eplerenone is out, right? According to Andrew Lottery, it's out.
What would you do in Japan?
Yeah, I think
Microphone.
the place of the leak spot is not very close to the fovea. I think the laser photocoagulation may be performed at that point, and if the leak spot is too close to the fovea, I agree with Dr. Burrido that ICG angiography is very effective to visualize the hyperfluorescence, the area of hyperfluorescence, especially the late phase ICG angiography. And PDT toward the area of hyperfluorescence is very effective to resolve the subretinal fluid.
And so when you said laser, you meant PDT.
Yeah, if it's close to the fovea, PDT is the option.
This particular case, I think, either PDT, or if it's a little bit out of the foveal area, you can even go with thermal laser, very, very light thermal laser.
Well, the one problem about focal laser is that in a series that we did from Mayo, the patients that had choroidal neovascularization had prior focal laser. So if you do it, use really low power.
Got to go very light.
All right, and just like Dr. Shields mentioned, there was a study published in 2020. It was a retrospective multicenter interventional case series, and it was a randomized double-blinded placebo-controlled trial that evaluated efficacy of eplerenone in patients with chronic central serous chorioretinopathy that was active. It was previously treatment naive, and they found that eplerenone was not superior to placebo for improving best-corrected visual acuity. So the patient elected to observe, and he presents 5 months later. And Dr. Sibillium, can you describe the next few OCT images, please?
Sure. So this is the right eye. He's still 20/20, looks normal. I don't see any new lesions, no subretinal fluid in this eye. And then the left eye, here we again see persistence of this subretinal fluid, again, shaggy photoreceptor appearance. Although go back, so interestingly, looking at the bottom of the cut and this area of the inferior macula, it does look like there's a little bit less subretinal fluid. In the prior vertical cut, there was extension of the subretinal fluid. Out here. So maybe a little bit less than prior, and we don't see that inferiorly. And then horizontal cut again. So he still has this persistence of this central pocket of subretinal fluid right in the fovea.
And then we have ICG and FA as well.
Yeah, here, so we have, looking at the right eye, on the left side we have IVFA, on the right we have an ICG image at 1 minute and 42 seconds. Looks normal in both images. Good choroidal filling here. I don't see any focal areas of hyperfluorescence or cyanescence. And
So I learned something from Jose Polito. I've only learned one thing from him. And he told me, don't call that cyanescence, call it hyperfluorescence. He can explain why.
Yeah, because it fluoresces. And cyanescence means it's more green, but this is just fluorescence, and it's not more green. You're using infrared, so there is no color at that point. So I think it's important that we use proper terminology.
And here we have IVFA and ICG in the left eye. At 1 minute and 13 seconds, again, we see redemonstration of this focal area of hyperfluorescence with kind of patchy signal surrounding it. And then looking at the ICG image, again, this focal area of hyperfluorescence. Question for Dr. Polito and anyone else that wants to add in. So I feel like in the clinic, typically, at least in service clinic, our reflex is to just get an IVFA on these people and not an ICG. What is getting the ICG add in terms of?
Well, actually, I learned this from my Japanese colleagues. In this case, you don't see a lot of changes in the fellow eye, but ICG is, you can see a lot more of these leaky areas in the choroid with ICG, and especially in fellow eyes, number one. Number two, if you were to treat, we were talking about treatment before, and fluorescein just showed that one focal spot, and you'd treat that. Well, you can see it's actually a little broader than what you would have thought, and a little closer to the fovea, and I would then lean more towards PDT. But let's ask the people that developed this.
So yeah, especially late phase ICG is valuable to visualize the area of hyperfluorescence, indicating the hyperpermeability of the choroidal. Yeah, that's right. Yeah, and this is very small area, but sometimes it's very large. So PDT toward the area of hyperfluorescence is effective, which is published previously in AJO and elsewhere. And if there's no hyperfluorescence, it's hypo, the PDT is not so effective too. Yeah.
So it basically gives you a better idea of where specifically to treat.
Yeah,
Okay.
that's right. The area of the pathological features underlying. Yeah.
So you would go with PDT in this case, you're saying? Okay. And this is exactly what our patient received. And so this is a retrospective multicenter interventional case series that evaluated efficacy and safety of standard photodynamic therapy with Visodine at 48 months in patients with chronic serous chorioretinopathy. And it showed that standard photodynamic therapy was effective and it was safe. And I was just curious, there have been reports of undesirable side effects such as choroidal ischemia, RPE atrophy, retinal thinning. Do you modify your setting there with PDT?
So usually I'll start with a half fluence for these patients. I think thankfully those risks are pretty low, which is good news. For this patient, when they were already improving, I would have actually thought about potentially observing this patient to see if they continue to improve as well. So I think that that's always an option.
So when you say half fluence, is that half time, 83 seconds divided by 2, 47 seconds, or is it half dose?
So it's not the half dose. It's not half dose of.
So it's just half the time.
Yeah.
So it's like 42 seconds, something like that.
There have been some studies done to look at that, but unfortunately, there have been some weaknesses identified with statistical test use and monitoring for and controlling for other extraocular risk factors. So further randomized controlled trials and not retrospective case series are needed to establish which exact setting would be the most appropriate. So he comes back 4 weeks later after receiving PDT therapy, and he is improved to 20/20. And Dr. Civilian, can you comment on OCT, please?
Yeah, so here we're looking at the left eye. We see nice resolution of that pocket of subretinal fluid. We do see some irregularity and disruption of the ellipsoid zone and ISOS junction, which is expected. given the chronicity and the shagginess that we saw in the prior images. Also some irregularity of the RPE, but good preservation outside the area of the prior lesion. And here we do have a better look at the choroid, which looks normal.
How often, and the question to the audience, would you follow this patient after this visit? So he is treated, he's improved. When would you see him next?
Probably see back like in 3 to 4 months.
Okay.
See how they do.
1 month, because recurrences sometimes occur. So
You're saying recurrence after PDT?
yes, recurrence once resolved and then recur again, and yeah.
But then you're not going to intervene with another PDT that quickly.
Mm-hmm.
And I think that the fact that there was basically one spot decreases, don't you think, the probability? It wasn't kind of a diffuse hyperpermeability. So, I kind of, in this case, I would lean towards what the other doctor, other Dr. Sivalingam said of 3 months, just because of that. But if there had been multiple spots, and that again is why the ICG is so worthwhile, I would see him earlier on.
Dr. Sivalingam, when would be appropriate if it does recur to repeat PDT?
I mean, I always worry about the RP damage and choroidal ischemia. So if I was going to redo it, I wouldn't do it before 4 to 5 months. Jose, do you use azithromycin at all in these patients to supplement at times, or you've given up that?
No, I haven't used Diamox in these patients.
Thank you, everybody.
We can see on this OCT that the RP is already beat up clinically, and we're also getting more optical transmission into the choroid, so it's thinned out.
Yeah, like I said, and again, it was a good series from Japan that showed that if you lose the outer segments, tells you it's been chronic, number one, and number two, the ultimate response is worse because of the fact that it's a sign of chronicity.
Yeah. And we have a second case. This is a 38-year-old female, presents with pain and progressive vision loss in the left eye for 10 days. Dr. Light, can you describe this fundus photograph, please?
Sure. So pseudo-color wide field image of the right eye, 20/20 vision. Media is clear, disc looks normal. I don't see any issues with the macula, and the vasculature looks normal. There's a little bit, that looks a little bit like cobblestoning, but this might be a little bit of lattice degeneration. Not sure if that's like an atrophic hole there, but otherwise fairly unremarkable.
Great.
Left eye, on the other hand, 2400 vision. It looks to me like the media is a little bit hazy, a little hard to tell the disc margins, unclear if that's just from the hazy vitreous or if there's maybe a little swelling there. I'm going to say probably from the vitreous, though. To point out the obvious, really profound peripheral retinal whitening here. There is extensive hemorrhage. To me, I think this is a vein here. It looks like maybe most of the hemorrhage is around the peripheral venules. Macula, again, difficult to tell, but it looks like there's probably some whitening extending into here as well. We're still able to visualize the vasculature here, but it'll be interesting to see how much flow, especially this looks pretty sheathed and sclerotic here, but no breaks, no specific vitreous snowballs that I can see, just a lot of hemorrhage.
And what about the arcades, arterial arcades coming out from the disc?
I mean, they're
Comment on
very
those?
attenuated.
Yeah.
It's, like I said, it's almost hard to tell where they are. So FA will probably be helpful for that.
Thank you.
This is fundus autofluorescence of the right eye. Looks like a normal signal. And left eye autofluorescence, again, we get a lot of blockage here from these multifocal areas of hemorrhage, primarily focused on what looks like the distal veins. Maybe a slight signal here in the macula, but not markedly so. And OCT of the right eye, both the en face and the B scan images look normal on this foveal oblique cut. And the left eye, again, clearly you can see marked changes here in the appearance of the vessels. There's some, you can see the hemorrhage around them. The B scan looks like, a hyaloid. And there's just a lot of vitreous debris. You can see how opaque that signal is. There's a very, pronounced vitreous body here. And there is marked loss of the inner retinal lamination patterns here. There's clearly edema and probably maybe some subretinal fluid here as well, clearly. And very hard to see the choroid here. RPE looks like it might be a little bit thinned as well. So that was a vertical cut. This one is a little bit oblique, horizontal, similar appearance. Again, much clearer. There's definitely subretinal fluid here, some intraretinal cystoid fluid, and again, just loss of the lamination pattern, suggesting probable ischemia. And IVFA wide field of the right eye at 1 minute, 15 seconds. This is full AV phase, very good perfusion. You can see some window defect in that area of what I thought looked like possible lattice degeneration there, but otherwise unremarkable. And left eye, a little bit of a dim image here, so hard to tell what phase we're in. It's probably arterial or maybe early venous laminar, but hard to appreciate. Not much more I'll say about this one. A little bit later, 40 seconds, we can see that there is some fill of both arteries and veins. Hard to tell if there's maybe some laminar flow there. But assuming that this isn't artifact, you can see some blockage probably from some hemorrhages here, but I'm already going to call and say this is profound non-perfusion out in the periphery, probably consistent with what we saw with all those sclerotic vessels. And a little further along, minute 48, again, assuming that this is not artifact from the lashes, which it appears to be too large of an area, this just looks like severe non-perfusion in the periphery. And again, confirmed here at 3 minutes and 10 seconds. I'll also point out there's a little bit of some leakage here. I think this is a vein again, so mostly venous leakage and just profound non-perfusion and a little bit of disc hyperfluorescence.
Yeah, and so his vision was 20/20 in the right eye, 2400 in her left eye, and she did have an relative apparent pupillary defect on the left. Her anterior segment examination, she had conjunctival injection, she had granulomatous inferior keratotic precipitase. Her AC had 3+ cell and 2+ flare, and there was some pigment on anterior lens capsule, and as you did notice, there were cells and vitreous as well. So Dr. Light, what kind of things going through your mind when you see a female like that, 38 years old with pain, 10 days of symptoms?
Yeah, so we're dealing with essentially a unilateral, probably combined retinitis, vasculitis with severe hemorrhage and severe ischemia. I would think, of the vasculitides that could cause this, I think the top ones on my differential would be probably infectious, viral in particular, whether it's HSV, VZV, or CMV. I think we would have to test for all of those. Some inflammatory conditions I'd be thinking of would be sarcoidosis. Behçet's usually bilateral, so I think less likely, but also can cause vasculitis. And lupus, young female, relatively young female, I would be considering that, though again, I might expect to see bilateral changes. The appearance to me kind of looks even a little bit like HORV, if there was any exposure to intravitreal vancomycin at any point. Just that terrible unilateral hemorrhagic vasculitis is reminiscent of that. I think other things, like on the infiltrative spectrum are probably less likely, but also can cause kind of a vasculitic picture. And then just other infections that I didn't mention before, syphilis, I think toxo probably less likely, tuberculosis can also cause like phlebitis, but I think less likely. maybe CRAO, I mean, given the non-perfusion, I guess you could keep on the differential. I wouldn't expect to see all that much hemorrhage, though.
You know, before the use of brolucizumab and vancomycin, this HORV, as Dr. Light called it, hemorrhagic occlusive retinal vasculitis, had been described in patients that didn't have any medication use by Blumenkranz and Clarkson around 1984 or so.
What was it from? Was it from just a plain vasculitis or lupus or?
They weren't sure.
Because it's such a classic picture.
Right.
I mean, when you see all the hemorrhages along the vein going out to the periphery, so classic.
There are some clinical features that tell you that it's almost certainly not CMV. Although if you're going to test for HSV and VZV, you're going to test for CMV at the same time. But CMV wouldn't give you that degree of anterior segment inflammation, and it typically doesn't give you the pain that you often have with acute retinal necrosis that you can get from HSV or VZV.
Thank you.
And just the rapid onset of progression would also be way, way, way atypical for CMV.
Makes sense. So we talked extensively about our differential diagnosis. So we'll just, in the interest of time, we'll move on to history. So if we talked also about some questions that you would ask. Is there anything else you would like to know?
Well, I think, you know, we want to get a good medical history. Are there any underlying conditions like lupus, other autoimmune conditions? I would want to ask about, you know, sexual behaviors, any high risk, you know, IV drug use, things like that. Obviously, any history of HIV. I would also want to consider that.
Great. So she reports history of anxiety and chickenpox in childhood, otherwise unremarkable history and review of system. She does report daily tobacco use as well. So we thought that the presentation was consistent with acute retinal necrosis. The American Uveitis Society put forth the criteria for diagnosis of ARN based solely on clinical characteristic independent of host immune status. And they involved one or more foci of retinal necrosis, rapid progression, as seen in our case, circumferential spread, arteritic occlusive vasculopathy, and inflammatory reaction. And usually presents unilaterally with vision loss, photophobia, floaters. Some of the risk factors is active or past history of hepatic infection, which can be found in up to 50% of cases. Fellow eye involvement is reported in about a third of cases, and usually within 6 weeks, but may be delayed. There are reports that treatment with systemic antiviral therapy will decrease the rate of fellow eye involvement. It begins usually with anterior inflammation, and as seen in this image, and the retinal lesions are usually discontinue as peripheral, and then they quickly coalesce to lead to full thickness retinal necrosis and vascular occlusion and significant inflammation. And we touched about a little bit on the differences between ARN, PORN, and CMV.
Can you go back to that slide about the three? Yeah, so for CMV, hemorrhage is very common.
Yeah, so I'm sorry, CMV, due to editing, it was moved. It was supposed to be over the last column.
The far right.
Yeah.
Okay.
The center one is PORN.
The center
This
is
looks like a
PORN
Mac to
and
PC problem.
Yeah. Yes. So the Wong and colleague proposed the following algorithm for treatment of retinitis of uncertain etiology, given that PCR results usually take several days to come back. And important to note that treatment with oral valacyclovir at 2 grams TAD does reach the same active concentration as it would be the intravenous acyclovir. So in patients who are that you're worried about compliance, if there's a systemic infection, you would admit and give IV therapy. But in other cases, outpatient therapy may be appropriate. So the patient underwent AC paracentesis, injection with Vascarnet, and was started on Valtrex 2 gram TAD. The other infectious workup was negative. And then a CTAP did confirm viral VZV. HIV was negative. And just in the interest of time, I'm going to skip some of the data slides. So 3 days later, she reported worsening vision and severe headache for a 3-day duration. Dr. Dung, does that concern you? Would you like to get imaging? What would you like to do next?
Yeah, it does, because you can get an optic neuritis with acute retinal necrosis, and they may need steroids for that. So I would definitely image.
And actually, there's been cases of temporal lobe cerebritis as well associated with it, and that's very important to rule in or out.
So she was sent to Wills Eye Emergency Room and underwent urgent neuroimaging, and thankfully that was negative for CNS involvement. And she then was started on prednisolone 60 milligrams daily. Dr. Dung and Dr. Polito, when would you advise beginning oral steroids or IV steroids?
So there are no controlled trials of oral steroids in acute retinal necrosis, so it's sort of mixed. I think everybody would agree that you want to have a good load of the antivirals on board. A case like this, even though the serum levels that you, as you described with high-dose valacyclovir are comparable to the IV levels, I would probably admit this patient. You're just never sure if she's got that much headache. Maybe she's not getting her medications as regularly as you'd like. I would probably admit and do IV steroids. But I would usually wait a couple days before I start steroids. I don't routinely do prednisone. One of your concerns in a patient who's got widespread retinitis like this is they are such high risk for retinal detachment. And theoretically, the prednisone might decrease the vitreous inflammation and maybe decrease traction and maybe decrease the risk of detachments, but it's not clear. I usually base the oral steroids on a combination of how much vitreous inflammation there is and the status of the retinal vasculature. In a patient who's got that widespread ischemia, I think it'd be reasonable to start prednisone. Even without the headache and the concerns for CNS involvement, I think it'd be reasonable to start steroids 48 hours after you've done the Vascarnet and the oral therapy.
Dr. Dunn and Dr. Polito, do you guys, with the presence of neurologic symptoms, do you guys push for an LP?
Not routinely, no.
Great. And then she received also a serial intravitreal injection with Vascarnet. How often, in cases like that, would you recommend an injection with Vascarnet?
So in a case like this, I kind of throw the kitchen sink at them just because the prognosis is really so poor at this point for a lot of different reasons. The widespread necrosis, the optic nerve involvement, the high likelihood of detachment. But I would probably do the serial Vascarnet injections twice weekly, probably for a couple of weeks.
Okay, great. And so she did receive serial Vascarnet injections and continued the oral steroids. And at 3 weeks later, on her latest follow-up, this was her final OCT. In the interest of time, I'm going to spare you the third case. If there's any last comments.
I have a question. So she was 38, you said? Yeah, so that was before the varicella vaccination. So the varicella vaccination came out about maybe 25 years ago. Are we seeing a reduction in varicella-related eye problems?
That's a good question.
I don't know. I don't think there's any clear decrease in the rate of acute retinal necrosis.
Maybe it's a little too early to see it, right?
Yeah.
Because 25 years, kids who are 25 years old or less have all been varicella vaccinated. So maybe the next 10 years we'll notice this.
Yeah, we did have a series of ORN this summer. Right. Thank you very much.
There's no compelling evidence. Some people used to use aspirin as an antiplatelet agent because of the retinal ischemia, but the data really don't support the use of that.
Great. Thank you. Excellent discussion.